You're listening to Shoe In, covering the ins and outs of all things footwear, from sneakers to heels, loafers to slippers, and every type of shoe in between. Brought to you by the FDRA, the Footwear Industries Association focused on retail, trade, politics, and fashion, helping create and enhance conversations on all things footwear. And now your footwear insiders, Matt Priest and Andy Polk.
Folks, welcome back to the show. Thank you for listening as always. We're going to get straight into this because one of the biggest challenges that we've heard from CEOs and C-suite across the industry is planning ahead during COVID. We think we know where we're headed. And in the same way, Matt, we thought we knew what was happening at the very start. We thought we could navigate COVID at the beginning, and as the factories were closing, what that meant.
We were fools.
Exactly. So, but we're starting to see the light at the end of the tunnel. We know a ton more about the virus. We know a ton more about the spread. We know a ton more about how digital tools are taking over. But there's still issues around travel. When can we allow our employees to come back safely to headquarters? How can we better manage information flow? How can we better plan ahead for demand, Matt? All these different things are huge on the minds of our CEOs right now.
Yeah, they are, Andy. And so my brother and I had a conversation over Zoom for the industry not too long ago. And the answers he gave were eye-opening, were revealing. He settled some of my anxiety around it, but he also provided answers to questions that folks had. We had one guy who said, "Hey, I was in China and this is my timeline." And my brother was like
diagnosing on live time.
Exactly. So this is a conversation with my brother, Dr. David Priest, who is the Senior Vice President of Safety, Quality, and Epidemiology at Novant Health. And this is a conversation that so many footwear executives listen in on, from Foot Locker to Shoe Carnival to many other companies. And so we wanted you to have this information. So we encourage you to take a listen. Dave, thanks for coming on and answering the questions about what's going on with COVID. I'm really excited to have this opportunity to share the space with you. Who knew our career paths would cross in this way, but here we are, right?
Yeah, exactly. Glad to be here. Enjoyed doing the podcast before, and regular listener to Shoe In. So I'm really excited to be here.
Yeah, we did that podcast a year ago, not knowing what was ahead of us at that time. And it's actually, I think, the number 6 most downloaded podcast out of over 260 episodes. So people are hungry for this information. And I think we know a lot more now than we knew when we were conversating back then. But as I sit here today, there are kind of these two competing narratives that are out there in the marketplace. One is we have these mutations or these variants, South Africa, the UK, and the Brazilian variant, that we're in this race against time to get people inoculated. And so that's out there, I think, creating some concern in the marketplace, coupled with, over the last 24, 48 hours, 72 hours, this narrative that globally cases are going down. And there's some optimism in the air. And so as someone who's right in the middle of it, how are you kind of managing these two narratives, and what would your guidance be to us as to how we digest them?
Yeah, absolutely. And my apologies. It gave me a new computer today, and now it wants to start installing various kinds of software. So hopefully that won't impair us. That's that beeping sound. I apologize for that. So interesting question. So we had the issue of we're excited that it seems like cases are going down. That's certainly something we're seeing in our organization. Over the last couple of weeks, we've seen a decline in the total number of cases we've had, the percentage of tests that are positive, and our hospitalizations. Our peak was really on January the 8th, which was kind of that post-Thanksgiving, post-Christmas rush. And so everything's continued to go down, which is very exciting. But we have to remember that even as things have gone down, we're still much higher than we were at some of the peaks back last summer. And so we try to, our healthcare teams are exhausted. And so there's a little bit of a reprieve, and that's very exciting, and we're glad. And I think the danger, though, is going to be what lies ahead as it pertains to variants. So we think to really be protected against COVID-19 that 70 to 85% of people are going to have some degree of immunity to this virus, whether either they've had it or they've been vaccinated, right? So currently we think 105 million Americans have had COVID, and we're about 33 million have been vaccinated or gotten at least one dose. And there's some people that are in both groups. So that's not near 70 to 85% of the population. So there is a danger, as you mentioned, as these variants move throughout the world, if they, elude the vaccines, that people could get infected again, or if they're more contagious, more and more people could get infected. So the other thing we have to consider going forward is if we're going to get herd immunity to 70 or 85%, and we're not even near that now, what about vaccine hesitancy, right? So we have people that, sometimes based on legitimate historic healthcare inequities and sometimes based on misinformation, the social media age, don't want to get vaccinated. So we don't even have enough people that are willing to be vaccinated. There's a ceiling to how much vaccination can contribute to herd immunity. So what we could be seeing now is a decline. We're getting past the Christmas and Thanksgiving rush, which is great. But then if these variants are contagious, then we could see additional spikes and peaks as we go, throughout the year. One of those variants is called B117. It's been the predominant variant in the UK. And CDC estimates that in March, it'll be the dominant variant in the United States. So just like the 1918 influenza pandemic, when it had 3 waves in that year, came and went, there is the potential that's going to happen here. So it does seem like mixed messages, right? On one level, you're like, oh, this is great. Things are getting better. We're going to come out of this tomorrow. And then on another level, you're being warned about variants, which could certainly come back. And I think both of those things are true.
Now, what about the vaccines and the impact on variants? I've heard things about the need for adjustments or booster shots. I've seen even the fact that those who get the first shot for those vaccines that take 2 shots, that even countries are thinking about extending the weeks between the 2 shots because they're finding immunity in the population just with that 1 shot. So talk us through each of these different vaccines and how to think about them. I saw the Johnson & Johnson vaccine is 65% effective. That sounds lower than 95%, but it's 1 shot and more stable. So I'm just trying to how do we balance all the different percentages that go into the effectiveness of these different vaccines?
Yeah, absolutely. So the Pfizer and Moderna products in general are about 95% effective, which is incredible. I mean, think about a typical influenza season, the flu shot may be 40% effective. And still is a very important intervention we have. So 95% is frankly unbelievable. As it pertains to variants, there are 3 you hear about talked about the most: B117 in the UK, B1351 in South Africa, and P1 in Brazil. They have similar mutations between the variants. As it stands right now, we think that the Pfizer and Moderna products give really good protection against B117 and good protection against the other 2, although maybe not quite as vigorous. And so we think they're still going to work effectively as constructed. Now, that doesn't mean that in each subsequent year that we're not going to have boosters like we have flu shots each year, where there's some adjustment to the formula, some adjustment to that mRNA, so that you get a booster that's more geared toward whatever the strain is going to be then. I think when you hear about the Johnson & Johnson product, you say, well, 65%, that doesn't sound great. Well, it was actually quite effective in preventing death and hospitalization, up around 85%. There are a lot of advantages to the Johnson & Johnson product for us who have to administer this on the ground. One is it's only 1 dose. So you don't have to get people to come back to get that second dose. And the storage requirements are much easier. You just put it in your refrigerator. You don't need the ultra low cold storage like Pfizer does. So we think there's some advantages to that. We're going to have to message this. I think sometimes people forget, it's important how well a vaccine works. It's often even more important how many people get it. So we know from flu vaccine and flu vaccine modeling, if you have a vaccine that's really effective, but not many people get it, it's not going to protect the population. If you have a vaccine that's only 20% effective, but everyone got it, it's much more helpful. So sometimes it's the density of how many people get the vaccine.
How to rearrange for the week after, maybe.
Sorry about that. Peter Yin, put yourself on mute. That would be fantastic. Thank you, my friend. All right, so you talked about administering the vaccine. We have a new administration that's taken hold. We have a variety of different viewpoints on the different administrations, as any diverse organization such as us. How are you seeing the distribution change in the Biden administration? What are expectations? I know you're part of the conversations with the North Carolina government. But what are you seeing as it relates to the distribution of the vaccine, so that particularly our retailers who are looking to get buyers back into their stores, looking to ensure that their employees are protected? How should we be thinking about the distribution of the vaccine as a whole as we sit here now?
Yeah, we probably need some of the people in the call to help with the distribution process. I bet there's some real distribution experts on this. So the challenge for a healthcare system like ours, we're about an $8 billion healthcare company. We've just gotten a new hospital. We've got 16 hospitals, about 650 clinics. So we're kind of moderate size, and we're in primarily North Carolina, but Northern Virginia and South Carolina. So we are prepared to give a lot of vaccine, and so we have to interact with the states in which we sit, and they have a process. And it's been a real challenge on the federal level, and the state level, and the local level, distribution, tracking vaccine. You probably have seen in the lay press how challenging that is. For us, we're ready to give all the vaccine they'll give us. And so we're in this weird place where they say, prove to us you can give vaccine, and then we'll decide how much you get. The state of North Carolina right now only gets 120,000 doses a week for the entire state. And so you have all this jockeying among healthcare systems and health departments to try to get those doses. They turn around and then communicate with whichever administration is currently they're dealing with to try to figure out what allotment they're going to get. The federal government says, we want proof that you've given every single one of your doses, you're close to it, and then we'll talk about getting you more. The state gets an allotment, and then they have to turn around and figure out how to divvy that up within the state. So we're part of those conversations. Right now, it's a fixed allotment. So an organization as big as ours right now, we're only guaranteed right now 6,800 doses a week, plus some additional doses if we're doing mass vaccination events. To give you an idea, just that group of patients age 75 and older, in our system, we have 150,000 people that are age 75 and older, and they're giving us 6,800 doses a week. So that's the kind of disparity we're seeing. I think there's some shift as the administration changes in philosophy and how they're doing things. A lot of it depends on if they're very confident that manufacturing is going to keep up with supply. We at one point we're kind of holding second doses. And so that's kind of ended because I think they're very confident in manufacturing, and we're hopeful as we get into March, we're going to see more and more doses, and that the Johnson & Johnson product is going to be approved, and we can start using that in particular settings.
That's awesome. Now, if you are managing a corporation, and one of the things that you do in your role is you advise obviously your patient network, but also internally your corporation about how to approach it, because you may have to be on the front lines of fighting the disease itself with your expertise as a doctor, but you also manage a ton of employees and have to advise the company how to treat those employees, when to bring them back into headquarters. Our industry is clearly remote working, but we have a lot of retail space, a lot of people that are on the front line selling products. So as you think about the vaccine rollout, how would you advise of your average footwear company here in the US about the best ways to approach reentry into the workforce, opening back up your headquarters, how to use HR to push out information on the vaccine, when not to do those things? There's just a lot of landmines out there as it relates to managing this in our population, and I'd be curious to know what your thoughts are.
Yeah, it's a good question. And I can certainly give you some kind of how we've approached it in our industry is somewhat different, but in other ways it's, very, very similar. Our approach in terms of the HR side is that we have been fully transparent with team members in healthcare. We already had pretty good kind of team member engagement in our organization. And as the pandemic hit, we started doing a lot more communication, probably things we should have been doing to begin with. And we have large question and answer sessions with our CEO and myself and other leaders. And the first thing we start with is we're fully transparent. We'll tell you everything we know about this. We'll tell you what we don't know. And doing those kind of calls and having that regular communication all the time in a time of uncertainty, certainly for us, has been helpful. We can dispel myths. We can give information. We can tell, hey, these are the things that keep people safe. We can talk about the importance of vaccine and masking, all those things. So I think in any industry that's going to be important, because there's going to be uncertainty as we go through the spring and into the summer, right? I don't think there's going to be a day where they say, we've reached herd immunity, and everybody comes out of their caves and their lights bothering their eyes, and they, we're off, we're going to do what we always did. Isn't it great? It's not going to be like that. It's going to kind of come and go. It's going to be slowly we're getting out of it. So we've taken the approach of more information is better than less. And I may say something one week, and the next week a piece of information changes the conversation, and I got to go back and say, remember I said that last week? Well, this is what new evidence suggests, we do. So we kind of approach it like that. We're erring on the side of caution, right? So everybody's super excited. The numbers are coming down. Can't we do this? Can I go do this? There's still potential risk, right? So the things that have kept us safe, we're going to keep doing those things for now. In our industry, we're going to mask. It may come to a time where we don't really have to mask, but we may be telling our patients that we're continuing to do this for your safety because you as the patient or you as the consumer are the most important thing to us. So this gives you some degree of peace that you see us wearing this mask, and that we know that our utmost responsibility as physicians is do no harm. We can't hurt you. So if it means I got to be more inconvenienced for a while because of it, we're going to do that. And then I think over time, what's going to happen is the same principles we've learned, we're going to continue to apply. So, if we're going to start getting together some, do we still need to mask? Are we doing it in big open spaces with a lot of ventilation? How long are we there? What's the density of people working there? And you can start to imagine, you can start to open things up. People are maybe more in the office than they were, but they still got some distancing. They're masking. Hey, our ventilation system in this building is really great. Oh, by the way, all of our team members have been vaccinated, right? Then the risk is going way, 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 way down, right? And so for us, we're not mandating vaccine in healthcare like we do with flu shots right now. And, over 90% of our physicians have been vaccinated, but not 90% of our nurses, I'll tell you that. So I think going forward is if I were in your shoes, I would go slow. I would message heavily. I would think what makes common sense, ease into things, promote people getting vaccinated, do all the safety things, and also be nimble, be prepared to go back the other way. If a variant shows up in May and we've got another push, we may have to go back to what we were doing, and that's okay.
Yeah, I like that because, one of the things I think about is maybe a retailer imploring that their floor managers and their retail employees wear masks, even if the transmission rate is very low and the case rate is very low, as a sign that the company takes the safety of its consumers very seriously. I like that angle to it. You mentioned social media at the kind of opening start of our conversation, and it's a pariah in so many ways. It's powerful in so many ways, in positive ways. But as I think through the best places to get information about COVID right now, I get asked all the time, what political news do you read, just based on the role of my job? Where do you get your information? Where would you suggest, the common citizen to point to and look at to get the most accurate information about COVID, about the variants, about the mutations, and all the things that we're talking about?
Yeah, it's such a challenge, right? Because I'm no different. I got a news feed, Google News or Apple News, whatever, and I had to read that thing every day, multiple times a day, because it's so fast and furious, and I have to be prepared for events like this in case I get a question like, "Did you hear this?" And it could have happened 10 minutes ago, literally, and I have to keep up with it, and it's a real challenge. I've told our team members straight up, straightforward news sources is what I've recommended them. AP News, Reuters, of course, CDC. The problem with it is it's just all article after article after article. There's rarely is there some summation of where we stand. I will say the New York Times has a couple of really great summary sites about vaccines and where we are and treatment and where we are that, in a few minutes, if you looked at that once a week, you can kind of get a feel for it. Even those nice summaries are very complex. I mean, they're 38 different vaccine candidates around the world, and you could get lost in all of this. But that's another great side if you want to get in a little more in depth. So to me, the Times, AP, Reuters, and CDC is kind of where I would start.
Yeah, the old school outlets. Now, the CDC, there's been a lot of talk about the political kind of maneuvering at the CDC, and like any administration, they're political appointees. I was one myself at one time. And so there's always that tension between the civil service and the political staff with any administration. But are you noticing at the outset, we're like we're in the third week of the Biden administration. Are you noticing any difference in how the CDC is presenting information to the public than it was in the prior administration?
Yeah, a little bit. I think they have a little more freedom to kind of to do their thing. And I think there was more tension before about that. And it appears the Biden administration has been a little more hands off to let them do their thing. Look, I think they have they have to win some trust back. I think they have to figure out the messaging. I think they need to get more sophisticated in their messaging a little bit than they've been, because there are a lot of really, really smart people there. And I think they'll get it right. I mean, part of the challenge has been, not to get too philosophical, but we need to do some work around our public health infrastructure in the United States, right? We have some really great things in healthcare here, but some of them, I kind of think about the American healthcare system as we're kind of a dilapidated house with a Ferrari in the driveway. We got some really cool tools. And when you need a really cool tool for a heart procedure or something, we do that better than anybody. But we've kind of ignored the house, the public health part, the foundation of the house. And I hope what will come out of this is, hey, we need to have, more invested into public health so that we can, when these things come up, we detect them quicker, the testing rolls out more efficiently. It's not enough to kind of beat our chest and say we're the best when obviously we aren't in some areas. We're the most technologically advanced in many ways, but some of the basics of public health we don't get right. So I'm hoping the CDC will pivot that direction.
All right, that's good. We got a question coming in. My encouragement to you all, our plans to keep the call 30 minutes, but it may bleed a little longer. Dave's allotted me an hour, so we can stay here as long as we need. But do submit your questions in the chat box, or you can unmute yourself. My preference would be the chat box just for ease of kind of maneuvering through them. But we have a question, Dave. The CDC news today said school teachers don't need to get vaccinated before returning to schools. Are doctors you work with thinking the same thing?
Yeah, it's a good question. And this is very emotionally charged, right? Children and teachers and all of those things. What the current data suggests is that you can reopen schools safely if you're able to socially distance the students, right? So, and some parts of the country have done that very effectively. Where I live in the kind of urban areas of North Carolina, most of the learning has still remained remote. And it's gone on for so long, there's a lot of hesitancy in the county I live in for teachers to go back, whereas surrounding counties have already been doing that. So in an ideal world, I think we want everybody vaccinated, and we're close to that phase of vaccination, meaning in North Carolina, we're in group 2. Group 3 will be essential workers where teachers are being vaccinated. So we've started the process of vaccinating teachers age 65 and older and teeing up teachers younger than that. I think schools can be reopened safely, even if every teacher hasn't been vaccinated. But obviously, each teacher needs to assess their own situation and have some flexibility in it. If you're a teacher that has multiple health problems and you're on medications that suppress your immune system, or you're caring for a sick person or an elderly person in your home, you're going to think about that differently than if you're an otherwise healthy adult. And fortunately, the virus has generally been not very severe when children get it. Occasionally, there are some complications children can have. So children themselves are pretty safe. It's the teachers that have to think through it. But if you distance and you mask, then a lot of school districts have shown you can do it safely. But it's a very emotional issue, and I understand that.
Yeah, that's a great question. Let's do this Mythbuster segment where I'm going to throw out a myth or two that I've read, and you just tell me why it's bananas or why there's something to it. One of the cool things about the vaccine is that it's not the live virus being injected into you, even though that's been kind of the historic way in which, and you can correct me if none of this sounds right.
Does he dress up like a woman?
It's the historic way in which we've used vaccines. But this is different. It's a signal. It's a DNA signal. Does it mutate your DNA?
And just stop talking. All
right, I'll stop talking.
I'm kidding. So it's a really good question. So traditionally, vaccines were just exactly what you said. Live virus, we make it weak, we give it to you, your immune system has a response. And then we moved to the phase where it was, we're not going to give you the whole virus. We're going to give you a protein. And then we wanted that protein to look like a part of the virus or the pathogen, and we want your immune system to respond to it. We've now moved to a phase of, we're not even going to do that. We're just going to take the very fragile instruction manual of mRNA and let your own cells make the protein we want your immune system to react to. So this technology's been around longer than people think. People say, well, it was the vaccine, it was rushed. Why are we doing this so quickly? Actually, mRNA vaccine technology has been around for about 10 years. And I think you're going to see it really take off in things like vaccines for cancer. You're going to see that fairly soon, the potential for a vaccine for the prevention of breast cancer. So in this regard, as soon as SARS-CoV-2 was sequenced, and the Chinese did that very quickly and publicly put it out there, then you could find the genetic code for the spike protein, the part of the virus that you want your immune system to attack. You take that genetic code, that mRNA, you put a little lipid around it, you put it in a freezer, and then you give it to people. It goes in the cells in your arm. That RNA goes into the cytoplasm. Remember high school biology, goes in the cytoplasm. It does not get into your DNA. It doesn't alter your DNA. And in the cytoplasm, your ribosomes take the little instruction manual and say, what's this telling me to do? It tells me to make a protein, and that protein looks like spike protein. And then your immune system reacts to it. mRNA is incredibly fragile. One of the reasons that it has to be, these vaccines are stored in ultra low cold storage, is they're so fragile. So that little tissue paper mRNA instruction manual disintegrates in about 2 days. So I really can't fathom any kind of way that these vaccines would hurt you in the long term because they're so fragile. Now, in the short term, you can have what we call expected effects. Right? We don't call them side effects around here. We call them expected effects, which sounds like a spin doctor, which I guess I am, in that you can expect your immune system is going to respond to the thing, right? So you're going to get a sore arm. You might even get a little fever or headache and got the blahs. And that lasts for a few hours, then it's gone. And that's particularly true with the second dose. So we've seen a lot of that. We've seen no real serious safety events with them at all. But it doesn't get into your DNA or alter your DNA in any way.
Does Bill Gates now track you once you get it?
No, they're already tracking you with your cell phone, so they don't need to spend the money to do that.
All right, noted. We do have some legit questions. Does someone unmute and want to ask a question? No? All right, we got another few questions. Is it realistic to see 100 million people vaccinated by April like the U.S. government is aiming for?
I think we're at 33, and we're talking about, let's just narrow it down to has at least gotten one dose. I think we're at 33 million right now, and we're now up to about, and somebody might look on the New York Times right now and tell me I'm wrong, but I think we're up to about 1.3 million a day. So you can kind of do the math. I think it's possible to get to 100 million by April. If we're doing 1.2 or 3 million a day, we've already done 33 million. I think it's possible.
Okay. We have an industry that loves to travel, and that's trade shows. It's heading to Asia for product development and manufacturing. That is meeting with customers and doing line reviews. It is a traveling industry, and none of us have been able to travel. We've been grounded for now almost a year. When you talk to our members, they're thinking maybe third quarter they'll start having people out on the road. But from where you sit, what's the realistic expectation to think that we might be able to incorporate travel from a liability perspective and from a corporate perspective kind of back into our daily lives as it relates to the movement of people for this industry?
Yeah, I think third quarter is not a bad thing to think about, but I think, again, you're not going to have a situation where it's just the way it was, right? So I think you're going to have to think through who it is doing the traveling, how are they traveling, have they been vaccinated, are they doing all the usual steps? I think it's really part of the motivation to get vaccinated, because it's not, 95% is not 100%, but if you got 95% protection and the people around you have been vaccinated, the risk is going to go way down. So I think third quarter is a reasonable thing to shoot for. I don't know, and you all are experts, obviously your industry, and I'm not, but I don't know you're going to anticipate doing the same amount of traveling you did pre-pandemic at that time, but I think you can start thinking about it. But even events that you plan, I think you have to think about how many people would be there, who's been vaccinated, how big the room is, again, what the ventilation is, how many people are going to be there, how long you're in the room, all the things that give you risk for getting COVID are going to still have to be on the table. I can tell you after my second dose of vaccine, and I've had 2 doses of Pfizer, that card they gave me, I went and had it laminated. And I put it in my passport because I thought I didn't want it to get, screwed up or, drop in a mud puddle or something. And I figured I might need it because I'd love to get out of town too when the timing's right.
Got it. We got some great questions coming in. What is the latest understanding about how long we might have immunity with the vaccine?
Yeah, so it's unclear. I think it's at least a number of months. You'll see these initial reports came out that said, protection lasts 3 months, and people got very concerned. Just 3 months. Well, it only been out 3 months at that point. So they kind of were periodically testing to see how long, antibodies and vaccine response lasted. So I think it's going to be, a number of months, maybe beyond a year. And then we'll have to see if we need a booster at that point. But my hope it's even longer than that. I would love for this to be like, oh, you get a booster every 5 years or something. That would be great. But if it takes a once a year shot for a while, we'll do that too.
Well, the Moderna CEO said COVID's here forever, right? And when you hear that, you're like, oh my gosh. When you hear that as an expert, what do you say to yourself?
I think he's right in the sense that it could be part of the respiratory viruses that, move around the world all the time like flu does. But at some point, a lot of people will have immunity, will have a good vaccine program, hopefully further therapies. We have some therapies now. They're not great. We have monoclonal antibodies we use. We have steroids. And so it's probably going to be circulating for a long time. He's probably right, for a number of years. And we'll have to, if we're protected, though, and we have effective therapies, then we can get back to doing what we want to do.
Okay. If you receive the vaccine or already have had COVID, can you still infect somebody?
Yeah, really good question. And you saw the AstraZeneca folks put out some initial data that says they think it reduces transmission. So the distinction here is, does the vaccine just keep you from getting sick and you still could get virus and replicate it and spread it? Or does it keep you from getting sick and keep you from replicating and spreading it? And there's not enough data yet on the latter. I think if people who've been vaccinated get it and spread it, it's going to be far less than someone who wasn't vaccinated. So when you get exposed to this virus and that spike protein binds to your cells, it gets in there in about 10 minutes. And then it takes about 10 hours for more virions to appear. So my hope is, what I think is going to happen is when you have a vigorous immune response to it, your immune system is going to attack it and prevent a lot of viral replication. Will it prevent all of it? Will it go to zero? Hard to know that exactly, but I think it's going to significantly reduce not only the symptoms you might get and keep you from getting sick, but also transmission, but it's probably not zero.
Do you know if China is offering vaccines to their population right now? I know they had a vaccine they were testing that was not as effective, and there's this weird kind of nationalism that seems to rise up when with competing vaccines and who gets which vaccine. Do you know much about what's going on in China?
Not a lot. I think they are offering vaccine, the number of vaccine products there. The Russians also have a product called Sputnik. They say is 91% effective. But the question's a good one because I think when you get nationalistic about it, if we immunized everybody in the United States and didn't think about the rest of the world, then there's going to be COVID all over the world. We've got to collectively, the whole world has to think about this because one nation can't keep its borders closed and vaccinate everybody and then keep it from spreading. It's really a worldwide phenomenon, and it really requires worldwide, cooperation to ensure that, there's some equity and you get vaccine across the world so that, it doesn't continue to spread or come back after you vaccinate the people in your own country.
Yeah, I think there's a lot of talk about, shutting down travel, people coming. I think at the point when the prior administration closed down to China, still people with special access, 60,000 people were still coming over, even under the ban for flights coming in. So there's really no stopping the movement of people and the movement of the virus as it relates to how it kind of transmits around the world. Is the booster the same as the original vaccine? If not, are they developing the booster now?
Yeah, so they are working on it. So I think what Pfizer and Moderna have said is, hey, we recognize that mutations occur and variants get created. We think what we have now does a good job, but we are prepared to develop a booster, and they are working on that. The nice thing about mRNA vaccines is they can be developed and manufactured very quickly in relative to other types of vaccines. So if you remember, traditional influenza vaccine was grown in eggs. So these like warehouses full of eggs, very finicky, a lot harder to manufacture, takes a lot longer. You're not even sure how effective it's going to be, et cetera. mRNA, once you know the genetic sequence, you can start pumping this stuff out. So they're already down that road. And I think, and it may be that even if you don't need a booster, what they're offering to people that haven't been vaccinated at all is slightly different than what, people got in the first wave. So the good news is I think those companies are already on that, and that this particular technology is a lot easier to change course quickly and manufacture a lot of vaccine.
Yeah, it sounds like almost like a software tweak, not to confuse people with another myth, but
no, I like that. I think that's a really good way to look at it. And, it's a real step forward. It's really, it's for those of us in healthcare, it's awesome. I know it seems scary to people, but it's not new. And the other thing we get is, well, did you skip any of the safety steps when you developed this? And the answer is no. You say, well, this seems quick. Well, a couple of points. One is the technology was around, but suddenly we had a common enemy, SARS-CoV-2. Number two is billions of dollars were poured into it from governments and industry to develop vaccines. In the past, when you want to develop a vaccine, you had to go around hat in hand and try to get some money. That wasn't a problem here. In fact, we've spent more in a year on the development of COVID vaccine than we've spent in the last 20 years combined to try to develop a vaccine for tuberculosis, an organism that a third of the world's population is infected with. So the money poured in, and then frankly, thousands of volunteers signed up to be in the trials. And so the normal process, nothing was skipped, is like suddenly you had all the resources and people you needed to do all the steps you needed to do to make sure it was safe. So, and I'm reminded, I sometimes get the question is like, well, you don't know what this is going to do to you in 10 years. Well, I can think about if this is a really fragile vaccine and it disappears in 48 hours, I'm not sure what it would do to you in 10 years, just intellectually thinking through that. And two, I'm reminded of like old black and white photos of moms in line with their children to get polio vaccine. Mm-hmm. Those moms didn't know what was going to happen in 10 years or in 50 years. They just knew they didn't want their kid to get paralyzed from polio.
Right.
So, and they lined up. And so I think, other generations have had to deal with this. And so I kind of think we're kind of in the same boat. There's a little uncertainty, but I think you weigh the advantages and disadvantages, you understand how the vaccine works, and the vast majority of the time for people, this is going to be a safe and effective vaccine for them to take.
Yeah, I've been reading a couple books around the founding of our nation, and at that time, how things were just swirling through the revolutionary troops, and things were just transmitted so easily, and people were dropping just like that. And I think in the West, particularly in the rich West, we are just so fragile. I was talking to Buddy Teaser, the CEO of Souls for Souls, about the work that the organization is doing in Honduras and in Haiti, where you can't social distance. There's no PPE. And they're more concerned about malaria, as they always are. And so there's just a fragility to our society that this thing has hit. It's relatively not that deadly, although it spreads very quickly and a lot of people get it. And so I'm not downplaying the severity of it. While at the same time, you've said we're kind of the victim of our own success because we've been inoculated from so many things, and we live in this very pristine society where you just don't get sick that often. And this has really been a gut punch to us, I think, as a whole, back to the kind of the public health question.
Yeah, I think, a lot of us are alive on this call who didn't die of measles or mumps or rubella or, yellow fever, all the things that vaccines have protected us from, or sewage systems have protected us from, or water treatment plants have protected us from. So we're not used to the idea that infectious diseases could kill off people around us. So, and that's part of the modern, anti-vax movement is I think people have just forgotten all that. I will say, we now, in terms of number of deaths, if we want to talk about influenza in particular, this is now the third largest mass casualty event in the United States history. So number one is the 1918 influenza pandemic. Number two is the Civil War, and we've just passed World War II. Mm-hmm. So if you talk about actual numbers of deaths, of course we haven't had a lot of flu deaths during all of this, but talking about numbers of deaths, we're up there, and it's gonna we're gonna have some more along the way, unfortunately.
Yeah. We got one more question. If you want that last question you want to dump in, you can send it to me. Talk about COVID tests. There's a lot of tests out there, blood tests, swab tests, home tests, driving through a tent at the bank, at the CVS parking lot. Which test is most accurate? And is testing still kind of the key, or is vaccination really the key at this point?
Yeah, it's a good question. So testing still has its place, and there are a lot of variations. In general, PCR testing that has rapid fluctuation in temperature that's done in a laboratory is the most accurate. But as you can imagine, it depends on the swab and whether you were shedding virus in that moment, how far they got the swab into where it needed to be, all that kind of stuff. But it's pretty accurate. There are other tests that are less accurate but useful for certain settings, like antigen tests are really good if you're not worried about every individual case. You're just trying to look for prevalence or do a whole big group of people all at once, like college students or that kind of stuff. So we still need better testing technology, and hopefully that will come. But for the most part, those PCR tests are the best tests, but it just really depends on the application.
Will the lack of flu spread due to social distancing this year, will that mean there'll be less flu spread in the coming years? What's the expectation on like the typical stuff that circulates?
Yeah, and that's a really good question too. So a couple of things about that. One is it's been incredible how little flu there's been for us. And you say, what's that about? Well, there are probably a number of factors. Number one, flu traditionally spreads around the world via international travel. So there's been a lot less international travel, but it hasn't been zero. Number two is, unlike COVID, flu, it tends to spread in children, and children drive that in communities. And children in a lot of places haven't been getting together. Number three is influenza isn't as contagious as COVID. So even our imperfect masking and hand washing and social distancing has probably made a difference. And the last thing, which is really an interesting thing that only people like me will probably geek out on, is there's something called kind of viral competition. So there's some idea that when people get infected with COVID, their interferons and other immune response kind of fire up, and it really prevents them from getting infected with influenza. Excuse me. So there may be the idea that the immune systems are being primed by millions of people, by the 103 million who've gotten COVID, and those people are going to be actually somewhat protected from influenza. So I would expect, and we've seen this with influenza and rhinovirus and other things over the years, I would expect as we get into the next flu season. In fact, I was just on a call today deciding which flu vaccines to buy for next year, that the flu will come back. As COVID goes down, flu will come back. And they'll say, hey, remember me? I'm responsible for the largest mass casualty event in U.S. history, and you guys are totally ignoring me. Well, you're going to pay. It's coming back. And just because COVID, its competitor will probably be less in the fall.
Make sure you buy that vaccine that's got a higher percentage effective rate. You got to aim above 40%, 45%.
Yeah, good luck.
I got questions keep on coming in as long as you got the time, brother.
Absolutely. Bring them on.
How long do you think antibodies will last? Is there a scale that the labs are not using because of cost? Does that make sense?
I think they're going to last a pretty long time. That goes back to, what's the immunity? I think probably over a year or maybe longer. We have the ability to check antibodies now, and there's a different antibody. When you actually have COVID, you make antibodies to a couple of different things. And if you've just been immunized, we check one just to the spike protein. So we have a way of measuring that if we need to. But I'm hoping at least a year and maybe longer.
For those that have had COVID, they continue to test positive for months. Does that make it more difficult to determine when someone is contagious? Those that have had the vaccine, will they also test positive?
So two good questions. Don't let me forget the second one. Gotcha. So people are not contagious after about 10 days if they have fairly normal immune systems. So we've dealt with this in our organization because sometimes doctors want to test to see if it's gone, or the patient wants to know that. And what can happen is the PCR test is really, really sensitive. And when it runs a certain number of cycles to try to amplify RNA and detect it. And we know that if it runs more than about 24 to 27 cycles, that there's no viable virus there. It's just some mRNA left over in your nasopharynx. And the tests traditionally run about 40 cycles, but the doctors aren't told that. The lab does that. They do 40 cycles and they'll declare it positive. But if it takes 39 cycles to find any evidence of RNA, people aren't contagious. So we've had to tell providers, and do not retest people the CDC says after a positive test, don't retest them for 90 days. And that's why, because the tests are really, really sensitive, and someone who's recovered and otherwise not contagious can have a positive test. I had to talk to an ear, nose, and throat physician because he wouldn't see a lady as a patient because she hadn't had a negative test yet, and she'd been 8 weeks out and felt fine. And so, my solution was stop testing. So you can feel pretty good after about 10 days that you're not contagious.
Well, I remember when I think one of your friends had gotten Ebola, talking about how you could find even traces of Ebola in like your tears in your eyes as it was kind of leaving your body. It just took time to get out. Didn't mean you were contagious, but there were still traces of it. Is that the similar thing that's at play here?
Yeah, a little bit. This is more the genetic material is present, and the testing doesn't distinguish that. It doesn't, when you have that PCR test just looks for the genetic material. It's not declaring whether someone's contagious. So whether someone's contagious or not has been brought on by studies where they actually did viral cultures to see at what point is there a viable virus that we can grow. Now, if you have an immune system problem, you could be contagious longer than 10 days. But in general, we tell people 10 days, otherwise you're pretty healthy, you're not contagious, and don't let people keep testing you.
One of the things that's unique to our industry, and Benji Rottenberg's question brings us up, it just takes me back to about a year ago when we're wiping everything down, right, with Clorox wipes, the groceries, just about everything, like the mail. And, for us, returns and exchanges, product that was taken home or shipped to a house and that's brought back in or shipped back, that has brought concern. And so our members have thought very carefully about returns and exchanges. When you go into a retail outlet and you try something on in the dressing room, they kind of quarantine it and take it away. How should our retail companies be thinking about returns and exchanges and the transmitting of the virus via packages that are given back and forth?
Yeah, it's a good question. In our world, we call inanimate objects that carry infections fomites. So in general, fomites have not been a big source of infection related to COVID. I know early on there was a lot of that, as you just said, wiping down groceries and things. As the dust has settled, that's less of a concern of mine. It doesn't mean you don't let some air out a little bit. I don't wipe down my mail. I don't, leave my groceries on the front porch, or I don't do any of that stuff. I wash my hands frequently. And I go about my business. I don't worry too much about something contaminating a hand and then getting into the airway of somebody else. So it's not that I wouldn't think about that or say, hey, we're going to let that air out for a little while or something. But I think that fomites as a source of infection for COVID is not common and not something I would waste a whole lot of time on. It's still very much more spread by respiratory droplets and air spread instead of off of inanimate objects.
Got a question. Someone went to China last January, got sick 2 weeks later. They got an antibody test in May. They didn't show antibodies. Is it definite that this person didn't have COVID? Real life diagnosis, doctor.
Yeah. So when were they there again?
They were there in January of last year. Like, as things were heating up in China.
Yes, I've run into this too. I think it's not definite, but it's less likely. So why is it not definite that they didn't have it? Well, you could argue that the case was mild enough where you didn't make an antibody, or you made an antibody for a little while, and by May, it wasn't present. I've had patients of mine who actually felt fine, but said, in July, I just couldn't taste or smell for a couple of weeks. And that was weird. And I've tested antibody and they were positive. I've had other people that had some respiratory thing about that time. And they said, I want to be tested. And they've been negative. So antibodies could wane over time. We're not always sure. And your immune response isn't all antibodies. Sometimes it's T cells and other things too. So it's not 100% that you didn't have COVID. I think it reduces the chances if in May you had a negative antibody.
Got it. This is my last question. This is the last question. It is February 4th of 2022, Dave. How are you feeling on that day a year from now? What do you think you're going to look back and what has happened over the coming year for us?
I'll be living in the rainforest of Costa Rica, so I will be unavailable for these calls. I think we are going to see a significant decline as we go through 2021 in COVID activity. I think you may periodically see little bumps in part of the world because of variants. and maybe some hesitancy to get vaccine. But we're going to be at a much lower level, kind of manageable thing. And we may be considering getting our first booster doses or yearly doses of vaccine. I think we won't be like we were in 2019 yet. I think the world was forever changed. But I think for the most part, it's a lot of regular business is going to be doing, what it was doing before. So I feel pretty good about that. And I'm hoping that occurs, this summer. Could you get a variant that's got a mutation that the vaccines just can't deal with? Yep, absolutely. But I would think by then, if we need a booster, we have it. We've got better therapeutics. We know more about how this is spread. We're getting smarter about how we do our business and how we travel, and that we're trying to live our lives a little more normally.
I look forward to your full beard from Costa Rica as you're enjoying life. Dave, I can't thank you enough. As I've told our mom, when, I know you're in high demand on the media side in particular, when her sons are on TV, it's never good news. It's either a trade war or a global pandemic. But I could think of no better person to come in and shed his knowledge with our membership base. So I want to thank you so much for spending time with our members today. And I really appreciate what you're doing on the front lines on behalf of Novant Health and the community there in North Carolina and the broader community. We really appreciate it.
Yeah, absolutely. And let's do it again sometime, maybe when it's really getting better.
Okay, cool. Folks, if you're an FDRA. All right, so that was awesome. My brother gave us more time than we even allotted because we had so many great questions coming in, Andy, as you know, and he promised to do it again. So I think we'll have this kind of continued discussion with him as he provides guidance to the footwear industry as my brother. I mean, it's as simple as that.
And I think, folks, hopefully come summertime, as the Priest brothers explain, we'll have a large number of people in the U.S. vaccinated. We'll have an even more clear picture. So as we go through these constant phases and mutations and everything like that, we'll keep having these conversations because all this is, it's a game changer when it comes to your demand planning. So I hope you enjoyed it. And until next time, please go back to all our many episodes, shoeandshow.com. Take a listen to all those important ones, especially our leadership series right now. I hope you're enjoying that. Please be safe. Please stay healthy. Please get your vaccine when it's your turn. And please keep listening to Shoe and Show. Until next time, until we can see you in person at some point in the future, Shoein is out.
Shoein has been brought to you by the FDRA, the Footwear Industries Association focused on retail, trade, politics, and fashion, helping create and enhance conversations on all things footwear. For information about FDRA, visit fdra.org.